And hello again, everyone. Let's look at lecture 4.2. Now, previously we talked about cohort studies, and prospective studies are a logical way, a direct way of studying risk. Again, there are limitations to a prospective cohort study in that chronic diseases and or rare diseases. So, chronic diseases and an issue of latency. So, if you wanted to do a prospective cohort study that looked at onset of heart disease, you would need to follow people from when they were young into their 50s, 60s, and 70s. Like the Framingham study, this requires time, effort, money. And what if the chronic disease, maybe not heart disease, but if a different chronic disease, what if it has a rarity to it, a rare component? Then you might sample a population, maybe sample 30,000, maybe sample 50,000 people, and you aren't able to find anybody in that sample that goes on to develop the disease. So these issues of chronicity and the rareness of things really complicates the ability to do prospective cohort studies. Retrospective cohort studies, they're a great way to assess risk, but limitations are there, and that you are reliant on the data collected by others. As well, do you have access to the data? If I had a data set that was this large, massive data set, and somebody came up to me and said, "Can I use your data set?" I would be like, no. Who are you? Like, I've done all this work. I'm not just giving that away. Plus, there's the issues of IRB and things like that. Looking at a case control study, this can help to address those issues related to rare conditions or conditions that have a chronic nature to them, or I should say chronic health disease. So a case control study, like we looked at in the prior week, it's a study that starts with the identification of cases, people with the disease, and appropriate controls, and then you retrospectively assess the exposure risk. So you go back retrospectively. Your cases and controls are identified in hospitals or medical clinics. Case control studies do not provide incidence data. You use an odds ratio as an estimate of relative risk. And again, it's good for examining rare diseases or disorders. Now, the advantage is it bypasses the need to collect data on a large number of people faster, not necessary to wait for measurement of exposure until effects occur. So here's a summary of characteristics of a cohort and a case control study. I won't read through these, but I'll invite you to pause the recording to look them over to see if anything doesn't make sense. Again, with your cohort study, your cohorts are groups that when they are assembled did not have the disease or the injury or the outcome of interest. When you assemble your cases and controls, they do have that disease. Here is a comparison of retrospective cohort versus case control. And again, I went over these a little bit last week. The big thing being that when you do a case control study, you know specifically who has the disease. And you identify controls. With a cohort, a retrospective cohort, you have an idea about people that have the disease or who have sustained the injury, but they all come from a similar cohort. Think about that example with the people that are falling in the skilled nursing facility. You're able to go back to a point in time where all those people share that baseline information. They did not have a fall at the time that they went into the skilled nursing facility. But you collected a bunch of information, and so you can look for potential risk factors. The case control is different because you have people who have the disease, and you find people outside of that hospital setting or outside of the medical clinic, or people that are within a different portion of the hospital or being seen at a different clinic. I think the point is, if you've got somebody that's seeing a specialist, well, you find a sample of people that aren't seeing that specialist. And then you're able to go back in time and ask them questions about potential exposures. So here is that look again at what a case control study is. And then here's an example. This one is female recruits to the military. And these individuals, you found a group of individuals who developed stress fractures, another group that haven't developed stress fractures, and then you maybe go back and ask them about their smoking habits. And look at their smoking habits maybe from a starting point even before they entered into the military. Here is a case control study design where they looked at familial predisposition towards ACL injury. And what they found is if you had relatives that had a prior ACL tear, you were 2 times more likely. And so within the paper, what you would find is their definition of the cases, where they found them, who they were, and then the controls, the same thing, where they found them, who they were. And they also presented 2x2 tables in the paper. And so you were able to double check their work, essentially. So that's kind of really nice. So again, the results here from it is a relative first, second, or third degree with an ACL tear. You were 2 times more likely to have one yourself. So when designing a case control study, you need to think about selecting cases, selecting controls, and measuring exposure. So your book talks about a case control study, and with a case control study, you want to have a representative sample of cases that arise in a defined population. So in this particular example, they were wanting to look at helmet use and head injury in Norway. So they were able to look at skiers and snowboarders from 8 major resorts, so about 55% of all ski runs in Norway. And they were able to identify people who had head injuries versus those who did not. And they went back and looked at behaviors related to helmet use. Convenience. Sometimes cases, again, are selected from hospitals and referral centers where uncommon diseases might be found. So in Portland, Oregon, near where I live, there is Oregon Health Sciences University. And that is where people come from across the state or parts of the region to work with specialists who will treat rare conditions, right? You wouldn't have somebody maybe seeing a doctor out in Eastern Oregon where the population is much smaller. That person would want to telehealth, or they'd want to drive into OHSU to work with the person who's a specialist in that area, the person who might be doing research on that disease. You get the point. So that's a great way to be able to identify people. Now, the book talks about something about a validity problem. These centers may attract certain patient populations, such as atypical cases, and that may skew the data. So you need to make sure that you are, again, having an operational definition that is focused on the disease of interest, and make sure you've got clear inclusion and exclusion criteria. It should be possible for both cases and controls to be exposed to the risk factor and to experience the outcome. So with the cases and the controls, with the Norway example, you would not have your controls be people that didn't ski. Right? Does that make sense? If they weren't skiing at all, that means they wouldn't be getting skiing related injuries, nor would they be wearing a helmet. if you have 40 to 60-year-old individuals going to a specialty clinic at OHSU, you would want to select probably Oregonians in the age range from 40 to 60 who aren't going to that clinic, but you probably wouldn't want to select people from South America as the controls. You probably wouldn't want to select people from the southern United States because there may be differences in, well, think about this, for example. Hold on. I just had to look something up and double check. Thinking about like MS. That's a disease where the prevalence increases the further away that you get from the equator. So would assessing people in Canada or the Pacific Northwest as your cases, would it be appropriate to compare controls from people living in Texas, Louisiana, Florida, places like that? That may not be the best controls. So the validity of case control studies depends upon the comparability of cases and controls. To be comparable, cases and controls should be members of the same population and have equal opportunities of being exposed. Now, measuring exposure. Validity of case control studies depends upon avoiding misclassification when measuring exposure. The best approach is to depend on complete, accurate records that were collected before disease development. So like pharmacological records, surgical records, surgical complications, things like that. However, many exposures can only be measured by asking cases and controls or their proxies about them, so questionnaires, interviews. Examples of things you need to potentially ask about: exercise habits, diet habits, over-the-counter, and recreational drug use. These measures can be subject to bias, though, right? Everybody exercises 5 days a week. They eat a Mediterranean diet. They only take Advil, and they never do illicit drugs. Odds ratio I mentioned before is the stat you use for a case control study. We can see here the breakdown from the 2x2 table and the math that would be done. Here's a 2x2 table now looking at that example, excessive exercisers versus moderate exercisers. And what you can see in that 2x2 table, following the A times D divided by B times C, this gives us a risk of 7.1 times. So again, the odds ratio is a good estimate of relative risk when doing a case control study. The odds ratio has a similar relationship to the relative risk in that an odds ratio that is greater than 1 shows that the group that you thought was the at-risk group or the group with the greatest exposure actually was. If the odds ratio is below 1, that means the group that you thought that was at risk actually was experiencing a protective effect and the other group was at a greater risk. And if the odds ratio equals 1, there's no association between groups. All right, this is the end of this lecture for 4.2 and the end of the lectures for week 4. So you've got discussion number 2 for this week. For this forum, you'll identify one common injury or disease that you evaluate and treat in your place of employment. Next, you will report 1 to 2 known risk factors for the selected injury or disease. However, some risk factors that are thought to be related to disease or injury have not been assessed prospectively. You will then assess the literature for studies that have supported or refuted the risk factor, presenting 1 to 2 references in your post. So what I might do for something like that, if I was interested in reporting on ACL injury risk, I wouldn't use that familial one because that was case control, but I might prospectively try to look at something like exercise habits. We talked about the Hewitt et al. Article back, I think it was in week 2. That was a field trial, randomized controlled trial, field trial that had an epi component to it. Might also take a look at other epidemiologic papers that have looked at things like hormones, that have looked at anatomical variation at the pelvis and hips. And so then I would then discuss those and provide the citation. There's also homework for week 4, and that'll also be due by the end of the week.